Hey, mental workers, you're listening to the Mental Work Podcast, the podcast about working in mental health for early career mental health workers. As always, I'm your host, Bronwyn Milkins, and today we are talking about helping survivors of family and domestic violence. Working with clients impacted by DV can feel daunting, especially when you're still building confidence as a clinician. In this episode, we're going to unpack how to approach this work with safety, sensitivity, and skill, and explore what survivors really need from us in the therapy room. Our guest today is Patricia Gallagher. Hi, Patricia.
Hi, Bronwyn. Thanks for having me.
It's so nice to have you on the podcast. Thank you for coming on. Could you please start us off by telling listeners who you are?
Yeah, so I'm Patricia Gallagher. I'm a registered psychologist from Melbourne. I've been practicing for 17 years now. I've got my private practice, which is Gallagher Psychology, 2 locations in Melbourne. My niche is domestic violence, family violence, and trauma recovery. And I've worked in a number of different settings, and it's been really good. But I also do teachings. I train sometimes in this space. I train different clinicians around guidelines and how to work effectively with domestic violence. And I'm also a board-approved supervisor, so I'll do a lot of supervision. And I'm an EMDR consultant, so I'll do consultation for people going through the accreditation.
Amazing. Gosh, that was a lot, isn't it? You've got a lot of hats that you wear.
Yeah, I do.
Yeah. DV can be a bit of a heavy topic. How did you come to be interested in helping survivors of family and domestic violence?
Yeah, so it started when I worked at an agency called Care, and this is when I was a provisional psychologist doing my old 4+2 pathway. That would have been the start of 2011, so quite some time ago. But from there, I learned a lot about the nuances around domestic violence. I probably worked in that more the heavy duty, obvious physical violence space where clients, just couldn't afford private psychologists, so they'd sort out the counselling services that Care could offer. So from there, my learnings and my practice and supervision, that really got me kind of well versed and passionate about this area. And just because there's not a lot of training in this space for psychologists. So I'm really passionate in stepping up, and having had the mentorship and the supervision, I now feel well placed to offer, early career psychologists or any psychologist across the board, just the confidence and the guidance in working in this space, because I think so many people think they don't have a client that doesn't experience domestic violence, but it can be in the subtle nuances as well. So I guess that's what got me, into this passion in this niche area.
Yeah, I guess one thing that stands out for me is I guess you pointed to that there's a continuum of domestic violence. So it can be from air quote minor behaviors or unhealthy behaviors in relationships right through to the person is at risk of dying by domestic violence.
Yes.
But one thing I wanted to ask you was how was that for you as a provisional psych, I guess, going into this agency? Because sometimes with provisional psychs, we're don't have the complex cases. What was that experience like for you?
Yeah, initially it was daunting, I won't lie. I guess like anyone, in early career, there's this sort of imposter syndrome, this sense of, oh no, I can't do it, or who am I to be helping and serving these clients that are going through such complex traumas, and the complexity of DV and family violence too. But through just a lot of encouragement, a lot of education, supervision, I was able to sort of break down those barriers I had, or those doubts as a young psychologist back then. And looking back, I guess doing the 4+2 then, I was doing a lot of client-facing work. So that gave me extra confidence and competence to work in these spaces. And then certainly I would have waves of doubt and imposter, but I was able to break through that myself through supervision and just debriefing with colleagues and fellow counsellors at the time that really
Yeah.
helped.
No, that's really good to hear. So it's while you're working with clients who, had complex trauma and difficulties in their lives, it sounds like you weren't drowning, you had people around you to support.
Absolutely. And
Yeah.
that's what I recommend and encourage strongly, particularly for early psychologists that do get faced with a DV client or a family violence client. Seek out a lot of buffer of support if you can, with supervision, with colleagues and people that are really well experienced in this area. That will
Yeah,
really help you.
absolutely. So for early career clinicians who might be unsure, how would you define family and domestic violence? What should they know about what it is and the different forms it can take?
Mm-hmm, mm-hmm. So domestic violence is, I guess, any violent or aggressive behaviour from an intimate partner perpetrator, where there's a power differential. There's an intent to harm, whether that be physically, psychologically, verbally, financially, socially, existentially. But there's just this level of coercion and dominance with an intent to harm. And that comes from either an intimate partner person, or it can be from a family member as well. And that takes it into the family violence realm. And family violence is more or less defined as the same dynamics at play, but just from a family member rather than an intimate partner.
I really like how you mentioned the different forms, like the
Mhm.
psychological, emotional, spiritual, existential, because I still think that perhaps a common myth is that when it says violence, it only means physical. Is that something that you come up against still?
Yeah, absolutely. Or people that just don't know the nuances of covert or emotional abuse or the coercive control. Look, coercive control is certainly a term that's getting thrown around a lot because I know certain states have introduced more formal legislation, and more, I guess, clients, but also more clinicians are getting well versed in knowing what this is. But I'm still finding that a lot of people don't know the covert examples of it, or when there's an absence of something, or when someone pulls away, and that's actually a form of DV, but not a lot of people can really identify those nuances or an absence of.
How do we know the difference as clinicians between what might be acceptable behaviors within a relationship and what is coercive? I'm thinking of the example of like, let's say one partner says to the other partner, just let me know when you get to the place where you're going. And the partner requires them to do that like all the time. So whenever they go to a new place, they need to tell their partner that they've arrived and that they're there and who they're with. How do we know that that just isn't the partner looking out for the other one's safety or if that's something more?
Yeah, it's a really good question. I guess when there's a pattern of that, that's clearly coercive because, someone else might be feeling threatened by that, or having that sense of surveillance, or check in. Because I think there's a difference between, being, you know, making sure the safety is intact, and that's okay, but there's an autonomy there. There's not a control there, or there's not an intent to harm or hurt.
Mm.
But when that's constantly done, and the person or the perpetrator knows that it's harming or creating distress psychologically for the other person, well, that's when there's evidence of abuse.
Yeah.
When there's green flags in that relationship, there's a level of safety being checked in on, but it doesn't come with surveillance. It doesn't come with power. It doesn't come with control.
That makes a lot of sense. And I guess, like, maybe early career clinicians listening to this, if they're unsure as well, it's like there's benefits to going to people like you who can help discern, like, okay, is this an isolated behavior or is this
Mm.
like an atmosphere or pattern of behaviors as
Yep.
well? And what's the context?
Exactly. Yeah, absolutely. Atmosphere is a really good word. When there's a constant atmosphere or sense, or yeah, just a real pattern, that's when you can tell that's DV.
Yeah, I got that word actually from Jess Hill. You'll know the book, like, See What You Made
She's
Me Do?
amazing. She is
Yeah, oh
good.
my god, it's such a formative book. I totally recommend it to everybody,
Yep,
but just I mean, it's a bit of a harrowing book as well,
it
like difficult to
is.
read at times, but
Yes.
like it really changed my understanding of DV. And yeah, she uses that it's not a single behavior, it's an atmosphere and what that means to
Mm,
you.
100%.
Yeah.
Yep, yep.
Mm.
She's very, very well versed.
Yeah, totally. So, what are some of the common emotional and psychological impacts you see in? I know they like the term victim survivors as well. I've written survivors here, but
Mhm.
what are some of the common emotional and psychological impacts you see?
Yeah, lots of second guessing, lots of self doubt, self gaslighting, belittling of self, a lack of agency, like an erosion of self esteem. I think a number of different experts will describe it as soul destroying. It's really soul destroying stuff, especially in that insidious realm of domestic violence, that sense of putting up with the abuse, and there's a sense of just going along with it, and it goes against someone's will to put up with it, but they'll do that purely out of survival. Or so
Mm.
there, I guess, some of those really kind of deep examples of what that looks like.
Yeah, because I think like maybe a myth that you can help us bust is like we can hear a client describe their relationship history and then we might think to ourselves, oh, that just sounds like a bad relationship. Can you just emphasize to us that what seems like a air quote bad relationship could really have significant impacts on the person?
Yeah, because there's toxic bad relationships, but usually that's when it's sort of two-sided. Those
Yeah.
when both partners will contribute in and indulge in toxic behaviors toward one another.
Yeah.
But in a DV context, it's discerning and distinct, but it's there. It's that sense of one person dominates over the other or will undermine the other. So it's one over other. And there's this term called reactive abuse. But that basically means the person that the victim survivor in this case, they're reacting maybe in a somewhat aggressive or abusive way, but that's because they're responding to what was done to them in the first place. So it's out of that flight, fight, freeze. But there's a nuance, but certainly on the outside, it can look like a toxic relationship. But if you really kind of dig deep, and if one person is sort of dominating that landscape, then it's DV, it's coercive control.
Yeah. With that, like, are there any questions that you might ask clients to work out, was this, say, a bad relationship, maybe unhealthy but not abusive? Are there questions that you can ask that definitively I suppose I'm asking for certainty in an uncertain thing, but is there any tips or tricks?
Yeah, I guess really looking for those red flags or how did the relationship start? Did it start with like grandiosity? Did it start with being someone being over the top? Did it start with what's called love bombing? I'm not sure if anyone here in the audience would be aware of a cycle of abuse. Back in the day, it used to be called the honeymoon period, where things would look really rosy and so easy for someone to get lured into that. These days, there's actually that model has changed, and it's now called the false remorse cycle of abuse.
Oh, wow. I haven't heard of this. That's so
Yeah,
cool.
yeah. And it's basically saying that clearly it's false because it's so cyclical. If it were genuine remorse, someone would take action and really own that they were being abusive and make changes to ensure that they're not harming their partner. But when it keeps
Mm.
happening, obviously that leads into that sort of slow erosion or build-up phase, and then it goes into that more overt form of abuse. But yeah, I guess sort of asking questions about early days of the relationship. Did the person talk badly about women or men, depending on the gender of the perpetrator, if you like, the
Yeah.
opposite sex? Normally there's that kind of putting down someone. What's their relationship like with their mother, with their brother, with their sister? That can give you
Yeah.
clues as well.
That's really helpful. I really like that cycle of abuse.
Mhm.
I've got it printed out actually because I find that when assessing clients who may have a presentation of DV,
Mm,
sometimes the picture can just really help and be a clear, like, this pattern is so known that we
yes.
have a word for it, a name for this cycle.
Mhm.
And like, does this resonate with you?
Yeah, definitely. And I think when clients are really visual, to see it can be so empowering. That psychoeducation is so powerful to name it and to allow that client to just digest that for a moment. But even for ourselves, like you say, Bronwyn, having a name, it's just like, okay, this is a thing.
Yeah.
This is actually really harmful.
Absolutely. Yeah, absolutely. So many new clinicians, I think they do worry about getting it wrong or re traumatizing a client who is a survivor of family domestic violence. What are
Yes.
some simple principles to follow when working with victim survivors?
Yeah, really ensuring safety. That's the number one thing. And yeah, I guess you've got to really assess where the client is at with regards to, have they exited? Are they on the precipice of exiting? Are they about to? Or is that a post separation abuse scenario? So you really want to be able to discern and assess which stage the client's at with regards to intimate partner violence or domestic violence. But also in that, once you've assessed the stage, really assess the safety, do some risk assessments, keep checking in that level of safety. Do they have other services like Orange Door, Safe Steps, or depending on, where the client is based, because of course Australia has different services nationally and per state for DV, crisis support. So making sure that they're really well versed and well connected with those other supports, which I think I want to speak about, where a lot of psychologists feel pressured to be the case manager or to be those other roles. which we can't be because it's not
Mm.
our scope. It's not part of our profession. But we can liaise with and break those silos, which a lot of clients face in DV scenarios where different services aren't really mingling or connecting. So it's really good to have, obviously, the client's consent to speak with other services and make sure they're really well versed. So that we don't take it all on, because that's where the overwhelm sits with a lot of early career psychologists, but even psychologists in later stages of their career sometimes, where that anxiety can come into this work.
Okay. I have 2 questions for you. I have lots more, but these are the main
Mm.
2 that come to mind. I think they're hard questions, so I'm sorry in advance. My first one is, what advice would you give to psychs who the client is saying, "Nope, I don't feel afraid. I feel pretty safe." But you as the
Mm.
psychologist is like, "There are, like, multiple red flags here." How do you manage that emotionally, and what do you do?
In terms of if they feel safe with their partner and
Yeah, but you as the psychologist is like, "This is not safe."
yeah, yeah. It's really hard, isn't it? Because you can't collude with a client or argue with a client. If that's how they feel, that's how they feel.
Yeah.
I think it's just a matter of us being patient, and holding safe space and compassion, because, of course, we want to take them out of that situation. Of course, we want to scream from the rooftops, no, you're in an abusive scenario or situation. But if they're adamant, they feel okay, they feel safe, there's not really a lot we can do other than kind of just be a good psychologist in listening, holding space. We might gently affirm, or maybe gently challenge things, but we don't want to challenge and put offside the client too much to impede on that therapeutic relationship. If they're not ready to hear certain things, it is what it is. We've got to
Mm.
work with that, which is
Yeah.
hard because it goes against our instincts. It goes against, we want to help treat and fix, so to speak, the trauma or the anxiety they feel. But if they're not owning that they're not in an abusive or relationship, or they're not calling it abuse, that's something we just need to really sit with, which is hard.
Yeah, I feel like it activates this part of many therapists, which is like
Mm,
their rescuer part or this like
mm.
fixer part. It's like, I've got to
Yes.
swoop in and rescue them. Is that something that maybe resonated with you? And if so, how did you manage it?
Yeah, it did. Early days, absolutely. I did want to go in and fix, like so many of us. But I really got told, not told, but I was gently encouraged by my supervisor at the time, just having to be patient
Yeah.
and check in gently with where the client's at. Could we do some other, I think, just to go back to your early question in terms of stability for the client and where they're at stage wise, give them some emotional regulation tools, teach the client maybe some breath work or some breathing techniques if they're feeling anxious and they don't want to talk about the abuse or don't own that they're in an abusive situation, but they're anxious. Okay, well, how can we move into other areas of therapy or treatment, regardless? So it might be just teaching them some cognitive changes, some cognitive reaffirming statements, like a little bit of light CBT here, perhaps, uh, just some different frames of thinking, like
Mm.
in terms of confidence, some anxiety regulation or, emotion regulation techniques for anxiety, helping them kind of work on behavioral activation if they're going through depression, things like that. I think it's
Yeah.
just about sort of changing the dial. If the client's not ready to sort of say or own that they want to work on that, we just have to kind of accept that and we can move into another part of the therapy.
Yeah, no, that's really good to hear. So it's like, yeah, work on our own reactions because I
Mm,
could definitely see, as you say, it would be a mistake if we were to
yes.
keep on insisting, like, it's
Yes.
you're in an abusive relationship. That would, like, as you say, put the client offside. It
Mhm.
would potentially cause a rupture in that
Yeah.
sense of safety with us.
Yeah. Absolutely. Absolutely. Because there can be such countertransference in terms of strong emotional responses we have in the therapy room. And a lot of supervisees will say that to me as well when doing this work. And I just affirm the same advice and the same guidance here that, yeah, we just need to own and acknowledge our stuff or our response. And definitely not go into fix it mode because and that's what I was told as well as early career. And that helped me a lot.
Yeah.
And I just had to be patient and ride things out. And
Mm.
eventually a penny would drop for the client and they might say, oh, actually, that thing you said to me 10 sessions ago, I've actually just realized it for myself. I've come to that realization. And then we can go, okay, yes. But we have to wait for the client to Something I always say to supervisees, it's about how we walk with the client.
Mm.
We walk with the client to ensure we don't create a rupture. And we really monitor our own responses as to keep in check that countertransference from our clients.
That's a really beautiful way of putting it. So this is the other scenario I had. So we've got a client who is in an abusive relationship and they accept that they are in an abusive relationship. How do we help them when it's not feasible to leave that relationship, at least for now? How do
Mm.
we help them when they're still in an unsafe environment?
Yeah, there can be a number of ways we can help them in that regard. It might be that we empower them to somehow process past traumas if they're not ready to exit now, but they're willing to look at what traumatic experiences and memories they've had from the DV that they do want to work on. We could help, utilize, say, EMDR or other therapy modalities to help process those traumas. In the meantime, do risk assessments to ensure their safety, because the exit is the most dangerous. So whilst they're not exiting, if the perpetrator or the person creating the abuse somehow senses that the other party is thinking about exiting, then we keep in check their safety, because sometimes they can just smell it or sense it from a mile off. So we
Mm,
want to check in with our clients about safety around that. I guess working on other tools and techniques in the meantime, I guess sort of evaluating some therapy goals whilst they accept they can't leave. Okay, what would you like to work on in the meantime? So asking those questions and really checking in with our clients, and I guess just updating our formulations and our
mhm.
conceptualization accordingly.
Yeah. I imagine the client would see that as really caring as well. So it's like
Mm.
we're being direct with them, we're communicating, we know that this is the situation. We're going to try and work out what you still want from therapy and how we can
Yeah,
help you.
yeah, absolutely.
Yeah. It
Yeah.
sounds really good. So you mentioned EMDR beforehand. I know that this is a really passionate area of therapy for you. You're an EMDR
Yeah.
consultant. So could you just tell us, there might be listeners who don't know what EMDR therapy is. Could you
Mm.
tell us what it is in a nutshell and what role it has in recovery for people who are victim survivors of family and domestic violence?
Yeah, absolutely. So EMDR stands for eye movement desensitization reprocessing, long word, formed by the late and great Francine Shapiro in the late 1980s. It is a therapy, is gold standard treatment model for processing and treating PTSD, post-traumatic stress disorder. And now it's got like a lot of great effects for depression, anxiety. It's a three-pronged therapy model designed to process and desensitize traumatic memories, help build up adaptive networks in the nervous system for a client, really embody a positive belief. So it's very different to CBT, which is top-down therapy. EMDR is bottom-up therapy designed to really match the physiology with the cognition. Undergo a bit of a body scan, close off the memory, and then you keep going until different memories are treated and processed. But it can also process and treat depression, anxiety, different areas that someone might be experiencing when going through domestic violence or family violence as well, including complex trauma or childhood trauma.
Mm. Yeah, amazing. And yeah, what do you think is its role for FDV victim survivors?
Yep. So a while ago, I spoke to, I don't know if anyone's familiar with Tracy Lynch, who's actually an EMDR consultant, and she's got a podcast, if anyone's a fan of EMDR here, called Understanding EMDR. I actually talked about it on her podcast
Oh,
2 years
cool.
ago, which is really interesting as well. But yeah, I think just utilizing different phases of EMDR based on where the client is at with the stage of DV recovery. So if they're early on, they're certainly not well placed, I don't think, usually to do the harder, deeper work or phases 4 to 8 to do the desensitization. It might be about stabilization, and it's about different phases. You can use them differently, and you can go back and forth, and it's so okay. It's not linear or one size fits all. You can accommodate and use this treatment like you would with any other therapy modality.
Yeah. And I guess like something that comes to mind for victim survivors of FDV is that they may have a history of like interpersonal abuse. So maybe
Mm,
there's been trusted figures in their lives who have broken that trust and abused
yes.
it. Is EMDR therapy good for when you have long standing and lots of memories in relation to that?
It is. And with lots of memories, I guess it's not about every single memory because there's so many, but I guess you're really looking at themes. Or if anyone's trained with schema therapy, it can be an excellent modality to integrate with EMDR with regards to what some of those schemas are developmentally and interpersonally as well, like mistrust or abandonment or defectiveness, shame, etc. So that can be incorporated into the treatment model, the treatment plan here as well.
How do you know if somebody, like a victim survivor of FDV, is ready for the desensitization part? Do they need to be out of the relationship completely to be able to go into desensitization or something else?
Not necessarily. If someone, it really depends. So if they've got good family support and secure attachment, I will often use phases 4 to 8 in EMDR a bit more efficiently because they've got the scaffold of support and adaptive networks from others to help them support and contain their trauma. And they can get that support elsewhere from, outside the kind of the DB, that they can seek, safe figures or safe people in their life that can
Yeah.
really help catapult that sense of recovery from other people. So I'll just go into that really quickly, but it
Yeah.
just depends. If someone doesn't have those level of supports, I'll really hone in on stabilization or emotional regulation and building those resources pretty steadily. It just depends on the level of support they have and where they're at. So it's kind of a not a one size fits all. It's just more about conceptualizing and working out those other levels of support before discerning and working out. But generally, yeah, it really just depends on their background support.
Yeah, absolutely. So, I guess the next thing with that is so during EMDR, or maybe even during the assessment or
Mm.
sessions with their client, they may hear things that are really scary, upsetting, of violence, of abuse. How can early career clinicians manage their own emotional reactions and avoid vicarious trauma when hearing these things?
Yeah. So attending CPD on DV, on coercive control, getting lots of support, education, information on that, lots and lots of supervision, lots of self-care in that, lots of checking in on one's own emotional state. Yes, attending CPD on vicarious trauma, building your own repertoire of self-care tools, networking with other friends, peers, colleagues that do similar work in this space, really getting that support from one another. I can't recommend enough. I was lucky in early career because I had, I guess, a counselling team where we could banter off one another and get that, just bounce off one another. And that really helped. So I can't recommend that enough as well. And just doing fun things, having some self-care with relaxation, with fun, just things that take away or distract even for, a couple of hours or, just some journaling as well, meditation, mindfulness, all the things we would encourage our clients, but how we might build that repertoire of emotional regulation for ourselves.
Yeah, absolutely. And I wanted to ask you as well, like with EMDR, with desensitization, like do you use the blind protocol sometimes? Like where clients like you ask them to hold the memory in their mind, but not necessarily tell you about it?
I don't use the blind technique or the no, but if a client is too dysregulated to use the full standard protocol, I might use the flash technique, which is somewhat similar, but it's less intrusive. It's just about really building something that's positive, and then you'll get a client to blink a couple of times, and you'll still process that memory, but it's done in a different way. Or you
Mm.
might titrate or use EMD or EMD and little r, just restricted sets. Just depends on that. They're the modifications I'll use if someone's regulated.
Could that be a way to also avoid strong emotional reactions to the practitioner?
It could be, and if the practitioner's avoiding, then really that supervision needs to be sought
I see.
because we can't have that impede on because the client's treatment or the well-being of the
Exactly.
client, because they could
Yeah.
really benefit from a full repertoire of going through activation. But a lot of therapists and even supervisees I see and consultees will be afraid of really entering that big realm of or what if the client has an abreaction, like a panic attack. Okay, then we can use our our toolkit as therapists to regulate with the client. We can pause, we can do lots of things, but that anxiety is very common, but we can't let that collude with the client's healing.
Yeah. So it really comes back to like the importance, particularly when you're working with FDV victim survivors, of that self-care and noticing your own anxiety and your avoidance in this.
Yeah,
Because
absolutely.
those feelings can impede, like you say, on the treatment of the client.
Yeah,
Yeah.
absolutely.
So you've worked across a number of systems like schools, agencies, private practice.
Mm.
It's a big question, but what do you think needs to change to better support victim survivors?
Oh gosh, so much, so much. Believability in the victim survivors, stronger justice and jail time for perpetrators, stronger mechanisms for the perpetrators to exit. I guess like enforcement systems, so much. It's really so multi-pronged. I think Rosie Batty talked a lot about this even in her talks. And I think the National Press Club speech she did possibly last year at the 10th year anniversary of her son Luke's death's anniversary, she talked a lot about these systemic changes really needing to be made, and just the exhaustion of these things haven't changed much in that time. He became Australian of the Year and really talked about these things. So a lot of systemic changes clearly need to be made. A lot of things I think outside our scope, which is the frustration, because clearly there's so much more we could do, but we can't because systemically there's just so many barriers. And we've got to just sort of sit with that and accept that. But I guess workplaces are starting to roll out DV grants, which is really good, DV leave. But yeah, that'd be a really good thing if workplaces could really make that much more simple. I've had a client recently that said that process was quite complicated, even though they had the policy intact. But it took 2-3 weeks when the client was actually financially struggling. So it'd be good if, these things could be streamlined and believed and, just in the first instance, granted and affirmed. So a more affirmative stance and a more trauma-informed lens I would like to see systemically, change as well.
Totally. How do you not get down about all of this? Because it's like, even hearing you talk, it's like from Rosie Batty that nothing's changed in 10 years. It just makes my heart go out to her, to every victim survivor. It makes me feel down. So I'm just wondering, how do you not get down, given that this is like your core thing?
Oh, trust me, Bron, I definitely do. And I think I acknowledge that and allow that for me to feel that. And then I just make sure I don't ruminate on that, because it's easy to. It's easy to go, oh, this is really shit. Like, I'm so powerless.
Yeah.
It's natural and it's okay to have those emotions and those thoughts. And we just got to be compassionate with ourselves in that. And that's all we can really do. But yeah, I guess in practicing all the self-care measures and good supervision to go, this is really terrible. And just to name that and accept that and, go with that really, but not letting it get you down. It's a bit of an art form, but I think over the years, in the 14, 15 years I've been doing DV work, I've really just had to make sure I've upkept my own kind of fun and self-care and my own supervision as well, and all these sorts of measures.
And I guess like for yourself as well, you do a lot of meaningful work in the area. So it's like you must see good outcomes or good progress or hear good things. And you're like, yes, this is working or doing something good.
Yeah, I do. And it's really interesting. This is well before I did EMDR, but this is years ago. I don't know if anyone's familiar with the framework, the shark cage.
Yeah.
It's actually devised by Melbourne psychologist Ursula Benstead with regards to helping build those boundaries, helping clients discern between sharks, so abusive, I guess, men, just statistically speaking, but I know that can be women too, and dolphins, who are people that are really beautiful and non-abusive and respectful. So a client messaged me, I think on some sort of social media platform, and I didn't really respond to it. She didn't want me to respond, but she just wanted to let me know that she got married, she exited DV into a beautiful, healthy relationship, 2 kids. The shark cage model that I'd done with her back in the day had really, really helped her, and she was ever so grateful. And that was incredibly moving to receive that message.
Yeah, I've gotten chills. That's such a beautiful outcome and just a real testament to your work and just the safety you've built in that relationship.
You. And that's the rewarding thing with it. Seeing the transformation, that just makes my heart sing. And what I love about this, and there's so much heaviness and deep sadness and deep traumas that really exist in this space. But I think, someone as a public figure, Yelena Jokic,
Mm,
she's gone through family violence and lived experience of mental health and borderline personality disorder and all these things. But she talks a lot about post-traumatic growth. And so I guess even in my kind of work as well, I instill that with clients about, there is a possibility of getting to the other side. There is an opportunity to even thrive. It's hard to see in the thick of things right now, but that could be a possibility. And it's just so beautiful when people can get into this sort of post-traumatic growth area. They've got meaning, they've got purpose, they've got, a new life. They're so free from, they're so safe.
mm,
That's just such a beautiful thing to witness and see in this area of
mm.
work.
Totally. Well, Patricia, this has been an awesome conversation. I know we've just touched the surface of
Yeah,
this topic,
yeah.
but I feel like it will be so valuable to listeners and to really help them understand this area a little bit better. What do you hope that listeners will take most from our conversation today?
Just the self-compassion for therapists. Don't feel compelled to fix all the issues, because we've got to remember we've got our code of ethics, we've got our ethical guidelines and legal guidelines we need to abide by. So let's just sort of hone in on our scope. Let's just be one part of that client's journey. Don't feel compelled to do it all or pressured to do it all. Just do what you do best. Hold the safe space, patience with the client, recognizing our own internal responses and emotions, working with that, seeking really good supervision, and upkeeping your own sort of self-care repertoire just to make sure you don't burn out.
Amazing. And if listeners want to get in touch with you or learn more, where can they find you?
They can find me on Instagram or Facebook, Gallagher Psychology. I'm also under Patricia Gallagher on LinkedIn. So if any early career psychologist wants to reach out to me for supervision, absolutely welcome that. I think they're the main, and gallagherpsychology.com.au, which is my website, which I'm also in the process of updating.
Awesome. Could you just tell us, you've been on like another podcast or two. Could you just tell us where you've been so I can pop the links in the show notes as well and they can hear more about you and
Yeah,
from you?
absolutely. So as mentioned, I was on the Understanding EMDR
Yep.
podcast with Tracy Lynch, mid-2023. So I talked about family violence and EMDR. So I really kind of did a deeper dive. So if you really want to listen to, I guess, how EMDR works with different phases and treatment in that regard, alongside intimate partner or family violence, you can listen to that episode, but also featured on the Neurodivergent Women podcast with Monique Mitchelson and Michelle Limmer. So I was also talking about DV and neurodiversity.
Perfect.
So they're probably the main two that I can think of. I think I've featured on a few other ones, but in terms of what would be relevant for psychologists, that'd be probably the main ones to look at.
Yeah. And you have a podcast as well, right?
I do, but I haven't recorded on there for a while. But if
Oh,
you do
okay.
want to check it out, it's called Phoenix Rising with Gallagher Psychology. In 2026, I really hope to relaunch that and have some wonderful guests, someone like yourself, I guess, and other people, just to rejig that. But so I recorded a couple of episodes quite some time, but it's still available on Spotify and Apple Podcasts as well, and all the other platforms.
Wonderful. I'll make sure all those links are there. Thank you so much, Patricia. You are a wealth of knowledge and just really excellent at communicating it as well. So thank you very much.
Oh, thanks so much, Bronwyn. A pleasure to be here today.
Listeners, if you found this episode helpful, please do share it with somebody else. It's the best way to get the podcast out there. That's a wrap. Thanks for listening to Mental Work. I'm Bronwyn Milkins. Have a good one and catch you next time. Bye.